Now I just have to live up to that billing. Thank you, Randy, for that most kind and generous introduction. And as Randy mentioned, I spent time in Middle Tennessee. I actually claim that I grew up in Middle Tennessee. I moved there after living in 7 other places. So coming back to East Tennessee is really very much a coming home, and I very much appreciate to be here tonight. The first thing that Randy took me to see when I landed was Valley Brook, the campus at Valley Brook, where so many of you I know have worked, are working, and are doing great things. And I was just totally blown away. And the hands-on knowledge that you all are gaining, the vision of global health that the dean and all of his colleagues are imagining, if you will, and are trying to put in place, especially given today's world, where we have had an object lesson in global health in the past month, 6 weeks. It's just so important, and I'm so honored to be here at ETSU. As Randy mentioned, I have a checkered career. Let's be honest. It's a checkered career. In fact, I actually showed Randy earlier in the week a slide with an orange and white checkerboard. But then we decided we wouldn't do that. But it is a career that has given me, as Randy mentioned, various perspectives. As a reporter who covered a state legislature for 8 years, saw policy being made, saw the sausage being made up close. As someone who then engaged in sausage making himself in the federal public health. And now as someone who, as Randy mentioned, for about the last 14 years, I've been trying to, shall we say, shape the sausage making as an advocate, first at the Pew Charitable Trust and now at the Center for Science in the Public Interest. And so I'm hoping that all of those perspectives will come into play tonight as we talk about what I call federalism in nutrition policy and how we make state and national and local policies work. How many of you think of Washington, Jefferson, and Adams as public health's founding fathers? I would suggest not many. You usually think of John Snow and the pump handle in London, or you may think of John Woodworth, the first Surgeon General in the United States. But I really think it's important, especially for those of us who are engaged in policy, to appreciate how, frankly, the constitutional system, the framework, the checks and balances, the state, the federal, what's set up, really does shape how public health policy gets made in the United States today. And to show you that I'm not alone in this crazy notion, Mike Osterholm, who has really been a leading figure at the state level, especially in public health. I first met Mike back in the 90s when he was the state epidemiologist in Minnesota, who was actually a lot smarter than we at the FDA were in figuring out one outbreak of foodborne illness related to ice cream. But I think Mike's point there, and he was making this in terms of Ebola and the response that we're having. And in fact, again, if you think about how we are responding to Ebola today and how we are calibrating the balance between national and state and federal, I don't know how many of you may have read that the new protocol that has been put in place calls for all the travelers that are coming from the 3 affected West African countries, when they are screened, to be given a kit, which they are then to take home. And then it's the responsibility of the state and the local health departments to, in fact, monitor for any symptoms and to make any decisions about how to prevent any further infection. So there really is this constant balancing act that is going on. And I think that, or I hope that tonight as I talk, I will sort of show at least my perception of how that balancing act works. Well, there's the theoretical framework of government, and then there's the reality of the institutions. And if there is complexity in the theoretical framework, in the way our government is structured, that complexity then becomes, if you will, magnified in, frankly, just the bureaucratic complexity of public health in the United States. And I'm leaving off USDA on this slide, and especially if you're talking about nutrition policy, arguably USDA should be up there every bit as much as the Food and Drug Administration and CDC. But again, on top of the federal superstructure, if you will, of public health policy making, you have the 51 state health departments, you've got the almost 2,800 local health departments. About 70% of those are governed by local boards of health, which again is not on that slide, but that's another complicating factor in how policy gets made. And then when you take a look at what the local health departments can actually do, one estimate that I've read says that about 70% of local health departments engage in rulemaking, which is a way that you make policy. But only 17% actually think of rulemaking as a primary way for them to do public health. They still tend to think of public health more, if you will, in the more traditional modes of public health. So what I would like to do tonight is talk about 4 policies, 4 major public health initiatives over the last 20 years: trans fat, menu labeling, sodium and sugar drinks, and talk about that interplay between state, local, and federal policy making, and how I think it has played out in those arenas over the last 20 years. Trans fat. Back in the 80s, 70s, 90s, it was ubiquitous in our food supply. All of those kinds of products had trans fat. It really wasn't until the early 1990s or so that the research began showing just how harmful trans fat in the diet was. There had been some research, but it really became a consensus, became overwhelming in the early 90s. Researchers like Walter Willett at Harvard and his team began doing the research, and the estimates were as many as 20,000, perhaps even as high as 50,000 preventable deaths a year because of trans fat in the food supply. My organization, CSPI, was one of the first to try to make it a policy issue. We tend to focus more at the federal level than at the state and local, although my colleague, Margot Wutan, her division does a lot at the state and local level. We petitioned the FDA, and our petition was a very straightforward petition based on the scientific evidence available at the time. At the very least, trans fat should be labeled. The nutrition facts label had just gone into the food supply. If you'll remember, back in 93, the law had been passed in 93, the food labels started appearing on products. Actually, I believe it was in May of 94 that it became mandatory and we had the official launch. CSPI said, at the very least, tell people what they're eating. Give consumers information. Well, things, as so often happens in policy, I was speaking to someone outside earlier. Anybody who gets into policy work should be prepared to be in it for the long haul. Policy does not take place overnight. And throughout the 90s, additional scientific evidence came into play. It became more and more clear about the harmful effects of trans fat, so that finally in 2002, the Institute of Medicine, which is a body in Washington, D.C., to which many agencies like the Food and Drug Administration, CDC, NIH, will pose scientific or medical questions, and the IOM will convene a panel of experts from academic institutions, from industry, from government agencies, and they'll review the science. And by 2002, the science was pretty clear to the Institute of Medicine. Unfortunately, in policy making, it takes time. So in 2003, with the Food and Drug Administration having been given the IOM's expert advice on the harmful nature of trans fat, the Food and Drug Administration proposed that yes, what we had requested back in 1994 should actually take place, that the label should include trans fat. We gave industry 3 years to do it because of compliance issues, trying to be reasonable. Well, industry pretty much saw the handwriting on the wall. And in 2003 and thereafter, product after product, company after company began taking trans fat out of their products. Now, one of the things that you need to understand about 0 grams trans fat in FDA labeling is that it really doesn't mean 0. It means 0.5 grams of trans fat per serving. So a product that has 0 grams trans fat can have as much as 0.5. Obviously, again, with the totality of the scientific evidence and with the concern about the cumulative intake and exposure of trans fat, there were many in the advocacy community who were saying, labeling isn't good enough. So what happens? Well, local governments, local health departments start taking up the clarion call. And what you see is the policy making going from the federal level to the local level. And you see cities, beginning with New York, Boston, Baltimore, Louisville, Kentucky, all taking action. And for the most part, they were banning trans fat in the restaurants and in the bakeries over which they had jurisdiction. And thinking back to that earlier slide about how once you start dealing with local health departments, then all of a sudden you're dealing with how far they have jurisdiction. Where can they actually reach? Where can their policy actually have an impact? But as I say, that list kept growing, and in fact, as late as July of 2013, Chelsea, Massachusetts put in place a ban on trans fat. Well, one of the things about when local policy making starts taking over and it's local policy versus federal policy, then you get that interplay, that balancing act that I talked about at the very beginning. And all of a sudden you have the question for industry about, do they really want to deal with however many jurisdictions at that point have put in trans fat bans? And don't they want a national solution? And there's pressure, in fact, then on the Food and Drug Administration as city council or local health department. And again, you have to remember some local health departments can take action on their own. In other cases, they have to get approval from the city council. For instance, I come from Montgomery County, Maryland, where the city council actually acts as the Board of Health. So there is more and more pressure that, in fact, the national policy of labeling is not good enough. Let's talk about the health benefits of even what that sort of crazy quilt approach to policy making accomplished. There was a study just published in September by a group of researchers based at Harvard. They've created an index of the healthiness of the American diet. And they looked at the American diet from 1999 to 2010. And they found there has been some improvement. That would be the good news. Not a lot of improvement, mind you. And they also found that, in fact, the gap between the diet of the lower socioeconomic families and the higher socioeconomic families, that gap has widened. All of that said, they attribute more than half of the gain in the healthiness of the American diet to those trans fat policies of the past 15, 20 years. First, the labeling, industry's response to the labeling by reformulating products, reducing the amount of trans fat. And so there's clearly a benefit from the policy, but it is policy that is not made in a straight linear fashion. It's policy that's made by pressure at the federal level, then pressure at the local level, and the pressure on both levels working on each other. So where are we today? As I mentioned, when you pick up a package with 0 grams trans fat, it's actually 0.5 or less. The Food and Drug Administration in November of 2013 proposed a ban, a true ban, where companies would then have to actually petition the agency for any use of trans fat. Now, part of that proposal also would allow some minimal use of trans fat, but it would probably not be at the 0.5 grams, which again begins to address the issue of the cumulative exposure. It's estimated that about 2 billion pounds of trans fat a year are still being manufactured, so it's being used somewhere. FDA has proposed a ban. We're now in the black box of FDA policymaking. Comments have been submitted to the agency. The industry is resisting the total ban. They're asking for something less. It's unclear where the agency is going to come down. But that is what happens in policy. That is how the policy has evolved in the last 20 years from our first petition in 1994 to 2004. Before I talk about those other three policy and the trajectory of those policies, I'd like to give you a little snapshot of Tennessee's health. This is data which was just released about a month ago from Trust for America's Health and the Robert Wood Johnson Foundation. It's an annual report that they do that takes a look at obesity in the United States and then takes a look at other attendant diseases related to obesity. Tennessee is one of 20 states with an obesity rate over 30%. As you can see, there was a small dip, but in fact, the trajectory has been going up. You take a look at childhood obesity, and again, you see that the best you can say is that there hasn't been much progress. It's leveled off. And what comes with obesity? A whole range of diseases. Diabetes. As you can see, Tennessee is not doing well there. Hypertension. Tennessee is not doing well there. Heart disease, arthritis, obesity-related cancer. That's a snapshot of Tennessee's health. So how do you address those health concerns? What other policy initiatives are there? Menu labeling is one such policy initiative. If you remember, I spoke about the NLEA, the Nutritional Label Education Act of 1990, which put the nutrition facts label on all of our packaged foods. Well, guess what? It didn't put nutrition facts information in restaurants, on restaurant food. It was one of the compromises that was made to get the legislation passed. Almost immediately after the legislation being passed, there were efforts, in fact, to try to address what many saw as a gap in nutrition policy in the United States. And the story here, unlike trans fat, begins sort of at the local level. This was really an initiative taken up by many cities, some states. And as you can see, by 2009, there had been quite a few efforts across the country to put in place menu labeling in either across the state or in the local jurisdiction. For the most part, they were pretty simple and straightforward. Putting in place the calorie information was the most usual information that was going to be required. In fact, Tennessee was engaged in this wave of local nutrition policy. And I don't know how many of you remember the story of how nutrition policy played out in Tennessee. But it's pretty indicative of, in fact, how local or state policy happens. The Davidson County Board of Health thought it would be a good idea to put nutrition labeling for the restaurants in Nashville, in Davidson County. Fairly straightforward. If you had 15 or more locations, put the calories on the menus, on the menu boards, give the industry time to comply. Well, there was almost an immediate response in the legislature. And one response was, well, if it's a good idea for Davidson County, it's probably a good idea for Johnson City, Kingsport, Memphis, Cookeville. And then there was the other response, it's a bad idea. And in fact, it's such a bad idea that even if Davidson County wants to do it, Davidson County should not be allowed to do it. And again, you know, that goes back to what I said at the very beginning about one of the things that you have to appreciate about federalism in nutrition policy is that it is this constant balance, this constant tension between local and state and federal, and what can be done at one level of government and what can be done at another level of government. So in 2010, the General Assembly passed legislation that preempted Davidson County from doing what the Davidson County Board of Health thought was right for its community. The governor vetoed the legislation. The veto was overridden. And so while the wave of labeling, menu labeling initiatives is sweeping across the country, and all those other places are doing it, it came to a screeching halt here in Tennessee. What would it have done? Going back to the slide about Tennessee having more than 30% obesity, according to the latest. Tennessee's Department of Health actually did an assessment of the Davidson County menu labeling initiative and said, if you make a very conservative assumption that 10% of the meals would have 100 fewer calories, in Davidson County alone, over the span of about 10 years, you would avoid about 16% of what would be the estimated weight gain. So it's not that you're going to stop the weight gain, and it was estimated in that study that the weight gain over a decade is about 10 pounds, but that you would at least slow the rate down. And for the state as a whole, it was slightly more than 16%. That's what the state health department said could have been achieved by menu labeling if it had been allowed to go forward in Davidson County, or if it had in fact been allowed to go forward in the state. So, as I said, menu labeling really pretty much started as a local initiative. It was being done by advocates, like my organization, or perhaps by an organization like many of you might be a member of in the local area. In 2010, the effort to actually extend it nationwide finally succeeded. If you'll remember, I said that when NLEA was first passed, there were about 3 or 4 attempts immediately after the passage of NLEA to put in place menu labeling, and they went nowhere in Congress. Finally, as part of the healthcare debate, it was allowed to be put into the ACA legislation. In 2011, the Food and Drug Administration proposed a rule. Essentially, it's a rule very similar to those local rules. The cutoff point for the proposed FDA rule is if the restaurant group chain has 20 or more restaurants. There is a huge debate, a huge fight going on whether or not menu labeling would apply to movie theaters. You can imagine what the movie theaters think of that idea. The rule has been proposed. Comments were received. Going back to the Food and Drug Administration's black box, where Randy and I once upon a time spent some time, decisions have been made. The final rule, many of us expected the final rule last spring. It didn't come out. Many of us thought we would see the final rule in the summer. It hasn't come out. Many of us are hoping we see the final rule in the winter. I'll come back next year and we'll update the talk and we'll see. The reality is, and again, this speaks to how policy is made and the dynamics that are at play, because for those of you who have not had the joy of engaging in federal rulemaking, federal rules are proposed by the agencies, but then they have to go through what's called OMB review, the Office of Management and Budget, and that's a black box that even I have no clue how it works. I've got some clue about the FDA black box. But we don't really know how the story of menu labeling and the policy will play out. And in fact, one of the interesting things about the FDA proposal is it may, depending on which learned public health lawyer, do I have any learned public health lawyers here? Good. Let the record reflect, I like learned public health lawyers. But there's a debate whether or not the FDA rule will in fact preempt all of the local rules that have been put in place. They will clearly preempt the rules with 20 or more restaurants, because that's what FDA rule applies to. But there may be, if you will, a safe harbor or a group with 15 or fewer restaurants, some number under the FDA rule, where actually a local health department could require more than the FDA rule. So that's still menu labeling, and whether or not how it will play out, how it will eventually look, is a story yet to be written. Sodium reduction. One of my favorite topics. I was talking to one of your colleagues who has spent some time in Finland, and Finland is actually a world leader in sodium reduction, population-based sodium reduction. The Finnish efforts actually date back to the 1970s because, surprise, surprise, the totality of scientific evidence, even in the 70s and 80s, showed that excessive sodium consumption was a problem and led to hypertension, stroke, heart disease. A quick aside, the USDA, and as I mentioned, I don't talk about USDA much tonight. USDA does a lot of the number crunching that tells us what we actually consume. USDA just published new numbers. For all of us average guys in the audience, our average intake of sodium on a daily basis is about 4,000 milligrams. We're supposed to be consuming about 1,500. So you can see there's a problem. For all of you average women, the good news is you're consuming about 2,900 milligrams. Still above the 1,500 milligram level, but not as bad as the male population. And in fact, CDC actually reported in September, they did an analysis of the data for children, and the average sodium intake for 6 to 18-year-olds in the United States today. Would anyone like to hazard a number? 3,500. Close, 3,300. Now, it's obviously a problem for children on two fronts. One, it can lead to high blood pressure for a child or a teenager. Two, it begins to establish for life the preference for salty food. So, sodium reduction and the need to have it has been pretty clear based on the science for decades now. The question is, what's the nutrition policy? How do we get there? How do we get sodium reduction to happen in the United States? Well, frankly, once again, the state or local health departments took the lead, at least from a national front. In 2010, New York City's Department of Health began something called the National Salt Reduction Initiative. They partnered with local and state health departments around the country, as well as NGOs, including the Tennessee Department of Health, get a commitment to do what could be done in their jurisdictions. But they also reached out to industry because of that 4,000 milligrams of sodium a day that I consume, or the 2,900 milligrams that a woman consumes, or the 33, somewhere between 75 and 80% of it comes from the food you eat that you buy in the grocery store, that you eat at a restaurant. It is not because any of us are sitting there with a salt shaker overturned. And so the question became how to work with industry. So New York City, with this group of partners from around the country, approached industry and they said, look, we know this is going to take time. So they set 2-year targets for reduction, 4-year targets for reduction. The reductions for packaged foods are different from restaurant foods. Everybody understands that there are different formulation issues that are going to be addressed or need to be addressed by industry, and that it's not one size fits all, and that in fact you have to work with industry, figure out what's reasonable, how it can be done. That was the National Salt Reduction Initiative. You'll remember my friends at the Institute of Medicine. They come back into play once again in nutrition policy. There was an IOM committee that was charged with looking at sodium. And in essence, if you will, they took the local approaches and federalized them. The Institute of Medicine took a look at what had been done for the last 40 years, which essentially were voluntary efforts by industry, and said, it's not good enough. It's not actually reducing the intake of salt. They called for the Food and Drug Administration to actually pretty much do what New York City had already proposed to do. except that they would be mandatory, that there would be limits for various categories of food, for packaged foods, for restaurant foods, and that they would be reduced over time. That was the IOM roadmap. Needless to say, it did not, shall we say, get rousing cheers from industry. And to this day, the Food and Drug Administration really hasn't taken any action on sodium reduction. We believe that they are working on something similar to the New York City initiative, but there will be a voluntary setting of targets, and it would give industry some leeway. Well, again, the question for policy is, if you reach a standstill at the national or at the federal level, then what's the appropriate response at the state or the local level? New York City is continuing to do what it's doing, but in the meantime, a number of states with money from the Centers for Disease Control and Prevention are trying to reduce sodium. And they've done a number of things, but for the most part, again, because of the jurisdiction issues, states can't address the national companies, international companies. The policies have been limited to procurement policies with regard to state agencies setting up nutrition standards for the foods that they purchase. In some states, they set up nutrition standards for the foods the state agency might provide its clients, if the agency has clients. For the most part, it's limited to state properties because that's where the state has jurisdiction. And that gets back to my original point about when you're doing policy, you get limited by your jurisdiction, by your authorities. What the state action can do is create different social norms as people see that, in fact, foods don't have to be salty, as people see that vending machines can have something in them other than salty foods. You begin to change norms, you chip away, but it's a slow process. Tennessee, I showed you the data about what came from the obesity report. Tennessee participates in what's called the Behavioral Risk Surveillance System. It's a survey that CDC creates modules for, and then states opt in and do various modules. In 2012, which was the latest data, the question asked was, has a health professional ever told you that you have hypertension? 40% of Tennesseans responded yes. Here in Upper East, 39%. East, if you go on down to Chattanooga and Southeast, it's above 40%. So you can see that sodium reduction is a real need in Tennessee. The last case study, if you will, sugar drinks. More CDC data. CDC released in August more behavioral risk surveillance system data on sugar drink consumption in 18 states. And guess what? Tennessee and Mississippi are number 1 and number 2. The consumption rates for one or more sugar drinks, including soda or added sugar fruit drinks is above 30%. I forget the exact number for Tennessee, but it's about 31, 32%. Mississippi is about 1% higher. If you take a look at the consumption of sugar drinks for youth, and I think that the cutoff was 18 to 34, Tennessee is up there in the top 2 or 3. Sugar drinks. Obviously, there are a lot of factors in obesity and diabetes, but again, when you look at the totality of the scientific evidence, sugar drinks are a unique driving factor in the disease rates that we're seeing. Sugar drinks are, even with the decline in consumption, and there has been a decline in soda consumption over the last several years, even in the decline of added sugars in the American diet, sugar drinks are still the #1 source of added sugars in the US diet. So what to do about sugar drinks? In 2005, not to toot my organization's horn too much, but in 2005, we petitioned the Food and Drug Administration. And hopefully, mercifully, most of you have absolutely no idea what GRAS is. GRAS is generally regarded as safe. It's a category that the FDA uses to determine what's allowed in the food supply or not. There are real issues with the GRAS policy, but that's a different talk. What we said back in 2005 was based again on the totality of scientific evidence. The GRAS status of added sugars in soda should be removed. And in fact, added sugars should then be considered a food additive, which again is another sort of arcane concept. But as a food additive, the agency would be able to require a health notice. And so in fact, by considering added sugars as a food additive, the agency could require soda companies to put on their cans a label that said something like, added sugar increases the risk of diabetes or obesity. 2013, we actually went back to the agency and said, well, you know what? Science has become even more clear in the last 8 years. What you really should do is determine what the safe level of added sugars are in sugar drinks and put a maximum limit. How many of you know how many teaspoons of caloric sweetener you consume when you consume a 12 ounces of sugar drink? How many? About 10. For a 20-ounce Coke, it's about 15.5 teaspoons. So, do you really need to drink that much sugar? In the meantime, the policy at the state level has been very robust. These are just some of the states, and you may be surprised to know Tennessee actually had a soda tax proposed back in 2011. But there have been actually somewhere in the neighborhood of 30 efforts to put a tax on sugar drinks or on sodas. Most recently, in 2014, California actually proposed and considered legislation to put a warning label. And it was going to be a very simple warning label that said, consumption of this beverage increases your risk of diabetes, obesity, and tooth decay. local approaches. You probably heard about the New York portion size, where the local Board of Health, using its authority, said 16 ounces would be a big enough portion. Doesn't mean you can't go ahead and buy a second 16 ounce, but consider what you've done with 16 ounces. Many people have read the decision that struck down the New York portion size this past summer as speaking to the merits. It actually never got to the merits. It was a jurisdictional decision, and again, going way back to my initial point about local boards of health, what their jurisdictions allow, what their authorities allow. The court in New York State essentially said that the New York City Board of Health is essentially limited to only proposing rules for which they have express authority from the New York City Council. Well, in fact, that arguably goes against 200 years of public health law in this country, where public health agencies have had a very expansive view of their powers and what they could do, and didn't see themselves as simply implementing what was approved by the local legislative bodies. I mentioned that states are taking sodium reduction by dealing with their jurisdiction on state property. That's pretty much what also is happening to some degree with regards to sugar drinks. There are efforts to restrict what's available in the vending machine that's at a state health department property or other state property. And you can see that that is taking place in sort of sporadic places around the country. But again, it's because there not being a national policy, then the state and locals step in and try to address their concerns. In fact, despite those efforts, there's a mixed picture. We just did a survey of what's actually in state and local vending machines, despite all these efforts at putting in place nutrition standards. And as you can see, sugar drinks far outweigh healthier beverage choices. Is there anything to be done at the national level? Where are we at the national level in these policies? Well, going back to my ever favorite topic, the nutrition facts label, there's a proposal in the newly revised nutrition facts that would put added sugars as a separate line. Industry is once again pretty much opposed across the board to that, arguing that there's no difference between natural sugar and added sugar and that the body processes it the same. And I'll leave that to nutritionists to debate and discuss. But again, giving consumers information that that soda has 16 teaspoons of sugar, we believe would be a useful thing. There's also something called the SWEET Act. I mentioned that many states, about 30 states and local governments, have tried to pass a tax. There's now actually, for the first time, a proposal for a federal tax on sugar drinks. The difference between this proposal and the state proposals, most of the state proposals base the tax on the fluid ounce. And so it would be a penny per fluid ounce. The tax that's been proposed by Representative Rosa DeLauro from Connecticut is a tax per teaspoon of caloric sweetener. So instead of a penny per ounce, it would be a penny per teaspoon of caloric sweetener. The notion being that one, what you want to do is tax the ingredient that you're concerned about, but also frankly gives industry an incentive to reformulate the product. That is my tour, if you will, through nutrition policy for the last 20 years. And again, you know, the point that I would make is fairly simple. Given our government, it is a constant balancing act between state, local, federal policy. The equilibrium shifts on any given issue. And it's always a question for those of us who are advocates to try to figure out where is the most effective, if you will, fulcrum on the lever that will actually get something done, whether it's at the local level, the state level, or the federal level. And as I was telling someone outside earlier, what you have to realize about policymaking is it's never from A to B. It's A to Z to G to T, and then finally, with a little luck, you get to B. Before I say thank you, I do need to do a quick commercial. Food Day. Tomorrow is Food Day. It's something that we've sponsored for the last several years. There are 8,000 events across the country. In this year, it's an attempt to address the issue of justice in food. So it's a question of food deserts. It's a question of in fact, how the workers who manufacture or grow our foods need to be safeguarded, their health and well-being. And yes, there are Food Day activities here in Tennessee. Knoxville has been going on for the last several days. One of the students told me that last year ETSU had a robust food day. I hope that you have a robust food day next year. Thank you very much. Sure.
Jim's willing to take a few questions if you like to pose some. So I'll ask you a question, Jim.
Sure.
Like so many policy issues, bundling tends to defeat issues sometimes. So there are folks who appropriately are concerned about taxes in general. How do you debundle a health issue from an overarching perspective on a policy standpoint?
Sure. I mean, you know, when we advocate, and we are advocating for the SWEET Act, for instance, when I go in, I first talk to a staff member about the health. It's one of the reasons why I began the conversation about menu labeling, sodium and sugar drinks by talking about health, because at the end of the day, it really is about the health. And even if someone may not be open to your particular policy solution, what's important is educating them about the public health import that needs to be addressed.
Thank you.
Advertising is a big problem, I think, and the profit margin or the profit motive pushes advertising at various vulnerable people like me and you. But I noticed the FDA, I presume the FDA, has required drug advertisements to talk at the end as fast as they can about the terrible side effects. And I wonder if part of this push for labeling menus will also go to labeling advertising. So Hardee's commercials will say, and by the way, there's 1,000 calories and 68 grams of fat in this hamburger.
You're exactly right. I mean, clearly, one of the issues in nutrition policy is the environment. And the environment is, for the most part, the marketing and the promotion of the companies. Given the First Amendment, there are some real difficulties in limiting commercial speech. And so, for instance, you're left with other alternatives. I mean, we, for instance, and other advocates around the country try to put pressure on food companies in terms of the advertising going to the underage audience. There was actually an effort to do it by regulatory action, and for various reasons, it got stopped in its tracks. But, that becomes, at the end of the day, you end up having to do some, if you will, non-governmental policy making by working with industry, getting industry to understand that they can actually gain some points by not advertising. We're actually pushing, at the risk of not trying to turn this into a promotion for CSPI or for our particular advocacy stance, advertising is a tax deduction. We're suggesting that perhaps it should not be a tax deduction. Might make a difference in the advertising. Yes, sir.
Now that we've eliminated trans fats, and I'm assuming that was often used for flavor or consistency, what is the industry now substituting, and what is the safety of that product to get the flavor back?
Well, I was going to say, in terms of sodium, there are a lot of innovations going on in industry trying to develop alternatives that are safe, but in fact provide flavor. I mean, and that's one of the issues with sodium reduction, because you're exactly right. Sodium is used not only for flavoring, but for consistency, for safety in some respects. That becomes a question, though, in terms of when you take something out and you start using something different, what really is the safety profile? Again, I didn't want to take us down the world of grass, but that becomes one of the issues of how, in fact, the Food and Drug Administration, frankly, today is not doing all that it should be doing in terms of maintaining safe ingredients, because they rely upon industry's self-determination of grass.
I think you just raised the issue about replacement, with fats, and how do we deal with the replacement of sugar with artificial sweeteners, which are now shown to have an impact on the biome, and we might sort of a whole another series of negative impacts.
Sure. No, and again, we actually, we question the safety of aspartame, and we've actually petitioned the Food and Drug Administration and have called into question their analysis. But on the other hand, there are things like stevia, a natural sweetener, which more and more industry is looking to. In fact, Pepsi just announced, I think about 3 weeks ago, that they're going to market a product here in the US that is 50% sugar and 50% stevia. So you're right to be concerned about things like aspartame, and again, it goes back to the whole issue of frankly, whether or not the Food and Drug Administration is doing the best job that it can be doing in terms of the safety of ingredients through the GRAS process, among other issues. I think.
One over here, and then I'll come over there.
Yes, my comments relate to oral health, which is a huge issue here in Appalachia. And I would just like to say that when it comes to the studies and the research, we tend to dilute the numbers because we're kind of an outlier when it comes to, say, consumption of soda.
Right.
And so, for example, Eastern Tennessee has probably more consumption than Western Tennessee, Southwestern Virginia, so much so than Northern Virginia. So just how does that kind of go into the research mix? Because it seems like everything's this nationwide sample. And my second question is related to oral health as well, is the focus is on the sugar, but the citric acid in some of these beverages can also do something called dental erosion on
Right.
the teeth,
Right.
which can be irreversible.
Right.
And so comments on both of those.
Sure, no, and frankly, one of the diseases which has been lost to some degree in the debate over sugar drinks is oral health, is tooth decay. People talk about sugar drinks in terms of obesity and diabetes, and then they go, oh, and by the way, tooth decay. And obviously, the science, as you said, not only the added sugars, but the citric acids. In terms of the data, that is an issue that frankly has bedeviled me for many years. Randy mentioned that once upon a time I was the Lord High Deputy Assistant Secretary for Health, harumph, at HHS. And one of the things that struck me was how much data we collected at HHS and how much of it was really useful and how much of it was useful to the community and how much we then got back out into the community. And all I can say there is, frankly, those of us who have been in the Federal Public Health Service and those of us who are still trying to shape the Federal Public Health Service, we need to do a better job in terms of getting the more granular data and frankly getting the data done in such a way that it's really useful for communities so that communities can really make their own decisions about what's the right policy for them.
We'll do one last question.
Sure.
Thank you for your presentation. During your slides, I noticed that a very major federal approach to solve these issues related to food is added them on the nutrition facts. And my question is, how effective do you think that these nutrition facts are for the public? Because I know when I go shopping, I never really look at them, and if I do, and I don't really understand the information presented on it. So do you think
Sure.
there are other alternatives to present this information in a more, I guess, useful, easier to understand way for the public?
Right. No, there is a lot of debate, and it's one of the, frankly, issues that the Food and Drug Administration has to weigh as it looks at the revised nutrition facts label. Just how useful it is and what do consumers take in. I think what we have learned over the last 1993, help me do the math, Randy, 21 years. 21 years of the nutrition facts label is it does change consumer behavior. People do look at it. The other point that I would make is it changes industry behavior. Having to list trans fat on the label changed industry's behavior a lot quicker than anything else we had ever done. And so that becomes one of the other real impacts of the nutrition facts label. It's frankly, I would humbly suggest to my friends in the food industry, it's one of the reasons they're fighting the added sugar line so hard, because they know that it will change consumers' perception. Now, I think that there are some things that they should still do with the nutrition facts label. I don't know how many of you go to the grocery store with a little scale that tells you how many grams something is. Teaspoons. We all use teaspoons. Let's put a teaspoon measurement on the nutrition facts label. Let's really make it useful. Thank you very much.
Jim, thank you very much.
Thank you very much.
As best Tennessee tradition, we have some parting gifts for you. we got some items that are heavy and hard to put in a carry-on bag. So, first of all, we have a gift for you. You can open later.
Thank you.
And then, secondly, we're pleased to present you the title of Honorary Professor in the College of Public Health. The first person at CSPI.
Well, thank you, thank you, thank you.
And thank you all. We have a couple of leading voice lectures next semester. I'm going to be announcing soon a couple of special lectures on Ebola that will happen next month. So stay tuned to your emails. And thank you all for being here this evening. And again, Jim, thank you very much.
Thank you.